Good afternoon, everyone. Welcome to our live Q&A session with Dr. Wu. I'm here with Dr. Wu. Dr. Wu, thank you so much for the wonderful lecture, for sparing us some of your time here on a Saturday. I'm sure everyone enjoyed your talk, and we will answer some questions. We have a very short Q&A session because of the extent of the talk. So I'm going to start off with one question of my own. Dr. Wu, you showed us in your talk a beautiful case of a patient with proliferative leukoplakia that was treated exclusively with imiquimod, and the result was outstanding. And I'm sure a lot of people in the audience would like to know your experience with imiquimod, and if there are any contraindications, if any patient with proliferative leukoplakia can use imiquimod. What has been your experience with this topical medication?
So thank you. Imiquimod has been used in other cases of proliferative leukoplakia and localized leukoplakia and oral warts in HIV/AIDS patients in the past. We just put together about 34 patients with 38 lesions, and the manuscript is right now under review. So roughly 1/3 of them had a complete remission with follow-up, like you saw. Another 1/3 had no response, didn't work at all. And then the third group had a partial response. And so some of those, they became so much smaller that we could then excise it.
Okay.
So the great thing is it's not necessarily a single modality treatment, but it is an exciting new way to, it's not new, but it's an exciting way to treat it in combination with other therapies. So imiquimod is used mostly for skin actinics and precancerous lesions, and it works really well. It's not as easy to use in the mouth, and I hope that the article will be accepted and will be published, and then you'll be able to see the actual protocol. They do get a very severe mucositis, very bad ulcers, very bad erythema. But for my patient, the one I showed you with the PL, they were thrilled.
I can imagine.
It was worth it.
No, I can imagine, because, moving away from surgery, from surgical excisions, and treating this very challenging disease just with topical medication, that's something amazing. And I'm sure a lot of people in Brazil would like or are eager to learn a little bit more about that.
Yeah.
Yeah.
The other thing I would say is that if any of you are interested in doing it wherever you are, just go to your dermatology colleague and say, I'm interested in doing this. Tell me how you do it. We do it a little bit differently, but they'll tell you how to get the medication, and you can treat it together with them. The other thing is, if they fail the imiquimod, there's another topical you can use, which I didn't have time to discuss because I was already over time, which is 5-FU. So you can use 5-FU with, but not alone, with calcipotriene, which is a vitamin D derivative. So they are actually compounded together. And in the US, they use this all the time on the face and on the arms and everywhere else. So it's 5-FU with calcipotriene. I'll write that down for you. And then you can also do intralesional 5-FU, which again, your dermatology colleagues will show you how to do. So there's very exciting, lots of other ways that we can treat this, not alone necessarily, but just it gives us options to use other medications, and then you can use surgery together with it or laser together with it.
The patients that did not respond well, were those patients with like a more hyperkeratotic lesions, or no, just okay.
Yeah.
Very, very interesting approach for sure. One more question. So far, PL has been classically known to be such a difficult diagnosis to make, such a challenging disease. You need the clinical, and it's a clinical pathologic diagnosis. And for most of the time, the majority of the time,
I didn't hear that last part.
it's a retrospective diagnosis. The majority of the time, patients come in and there's a biopsy done, and then he comes back again with another lesion in another area. In your opinion, are there any parameters in the near future in which we can make a prospective diagnosis of proliferative leukoplakia?
Yeah, it's interesting. I would say that in my practice, by the time the patient comes to me, it's well established. It's already proliferative.
Okay.
Again, I don't use multifocality as one of my most important criteria. It's the size and how large it is. To me, it's obviously proliferating. It's now 4 centimeters, right? But I think the single most important thing truly is to use the architectural criteria that was put together by 2 groups, my group, showing that local and proliferative, they have the same architectural criteria. The WHO, which recognizes all the criteria except for atrophy, which I don't agree with. And then the Lester Thompson group, which was a consortium of 20 pathologists, head and neck and oral, and they basically had the same criteria.
Yes.
So if you use those criteria, you will diagnose it almost immediately. And that is true for both the localized as well as the proliferative, even without a photograph.
Yeah, we were talking backstage about how atrophy should have made the classification as part of an architectural feature of dysplasia.
It's very important.
Very important. We have one comment by Marcelo Sperandio. He says, many thanks for sharing your experience with us. In case you're still there, I'd like to ask whether you believe that if we are able to standardize reporting, we may eventually see that ordinary leukoplakia is actually really low risk, and perhaps the transforming ones may all essential be PL.
Oh, interesting. I think that, thank you. Yeah, I don't think that the localized ones are necessary. So I think when you say ordinary, you mean the single site unifocal localized leukoplakia are necessarily low risk. I think it just depends. The risk of malignant transformation depends on the acquisition of mutations. So if they have only architectural features and it's unifocal, I remove them because I'm not going to wait for them to get the second hit, and the third hit is squamous cell. I'm not waiting for the second hit, which is the dysplasia. When the lesion is large and is proliferative, and it is the single, it doesn't matter whether it's first hit, second hit, whether it's only architectural, has already got obvious moderate to severe dysplasia. The patient's in trouble because the lesion is huge. You can't really treat it. It's too big. So I think, but the way I report in my lab is absolutely standard. It's standard for every leukoplakia. Remember, I don't call bite injuries leukoplakia. I don't call alveolar-rich keratoses in the retromolar pad leukoplakia. Those are bark. So I have a very specific way of reporting. Next one. My experience with PL was quite different in Europe. My mentor was Dr. Bacon in Guatemala. Yes. Affecting dorsal tongue with deep application, thin look at this, then develop focus at that. Yes. And I think there's a person. We certainly see, I think you saw in the paper, which had the 9 panels, that we often will see leukoplakia on the dorsum of the tongue that can be solitary or huge, greater than 4 centimeter, in which case you call it proliferative. Then they develop dysplasia. Yes, we expect them to develop dysplasia. This doesn't mean they have dyskeratosis congenita at all, because if they did, they would have other features of dyskeratosis congenita, and they would have the DKC gene, right? So that's easy to rule out. Do they have DKC? Just look for the gene. And then they have the other features. They will have bone marrow failure, and they also have skin lesions, right? They get the poikiloderma. So if they just have solitary white lesions on the tongue, they have leukoplakia, which may be localized or proliferative, doesn't matter. And their chances of developing dysplasia is extremely high because that's what we know leukoplakia does. and about 15 to 30% of them would get cancer.
Yes.
And if it's proliferative, it's greater than 60%.
Yeah, that's true. Dr. Wu, I am not seeing any more questions. Thank you so much for responding to the questions while your lecture was being played, because that actually helped us with the Q&A session. Yeah. I think we can end our session. Thank you so much. Once again, on behalf of the Brazilian Society of Oral Medicine and Pathology, I wanted to thank you so much for being with us and for teaching us about proliferative leukoplakia.
It's such a pleasure. It's an exciting field. I hope all of you will get involved and do great research on this. And thank you, Ana Luisa. And thank you to all the organizers. Have a wonderful day. Bye-bye.
Bye.